Hello, this is Jim Landman in Kaufman Hall's Thought Leadership Group. Welcome to today's webinar on Healthcare Performance Improvement Insights. A couple of housekeeping items before we begin. First, we welcome your questions at any time during the webinar. Please submit them using the Q&A function on the webinar platform. And second, this webinar is being recorded. The recording will be available on our website under the Insights and Reports navigation tab within the next day or two. Today's webinar will be moderated by Lance Robinson, a Managing Director at Kaufman Hall and leader of our performance improvement practice. I'll now turn the webinar over to Lance to introduce today's presenters.
Thank you, Jim, and good morning or good afternoon, depending on what part of the country you're in today. Appreciate everyone joining our performance improvement webinar. As Jim mentioned, my name is Lance Robinson, and with me today I have a couple of presenters that will be going through the content with us today. First with us today is Matthew Bates, Managing Director in the Physician Enterprise Practice. Therese Fitzpatrick, SVP within the Performance Improvement Practice, specializing in workforce optimization. Mark Newton works in our revenue cycle focus area, specializes in the business office and the revenue cycle. And then last but not least, Brian Fazarski in our Performance Improvement Practice, heading up our care transitions, care management group. So we thought we would start the webinar with some highlights from our 2022 Performance Improvement Survey. We do this every year and send out surveys across the country and get responses back from providers across the country, like I said. And we have a couple of observations here that I would like to ask the group about. Does anything really stand out to you from the survey that's interesting, that's something that was surprising as part of the results that we got back from our respondents? One thing that I found interesting was that 66% of our clients are having to run at less than full capacity because of staffing shortages. I know that's a real challenge for many of the providers out there. Therese, did you have anything that you wanted to add to that?
Yes, so in addition to that, understanding that the demand side is being so significantly constrained, the other sort of side of that is 98%, nearly 100% of our respondents talked about the fact that they have had to raise starting salaries. But we are finding in some markets that this could be as high as 15 to 20%. And we all know that once those salaries are raised, those are not costs that will be recovered, that we will continue to pyramid that on top of that year over year. Another very significant finding.
And Mark, I noticed that the denials have increased 67%. With our respondents. This continues to be an issue with the payers denying claims across the board. Can you comment on that a little bit?
Yeah, we've really seen that across the whole country with all of our clients in the last year or two. I think the primary focus everyone is experiencing is on the clinical side, primarily medical necessity, and that's the whole inpatient versus observation challenge that we keep facing with payers. And their rules are kind of muddied and changed constantly, and it's hard to keep track of what they're expecting. And also around the authorization, they've become very strict around authorizations, not only what service was authorized, but also even the time frame within those. So becoming a bigger and bigger issue. It's been a struggle across the board for everyone.
Great, thanks, Mark. And Brian, I noticed that a lot of the respondents are reporting an increase in length of stay over the past year. 69% report an increase. What's driving some of that?
Yeah, there's of course there's multiple factors that are driving it, but the one area that we definitely are seeing is difficulty with discharging patients in the nursing homes or home care agencies not having enough staff to care for those patients. We're also seeing delays with insurance companies that are maybe holding up the patient from getting authorized for reimbursement or authorized from going to nursing homes.
That's great. And then Matthew, I'll just ask you real quickly about the APPs and those being used more in a more meaningful way with the practices across the country. Any thoughts there?
Yeah, I think we're seeing a significant increase in the adoption and teamwork between physicians and APPs. There's a fairly direct correlation actually emerging in performance data showing that those organizations that are figuring out how to effectively leverage nurse practitioners, physicians assistants, certified registered nurse anesthesiologists are outperforming their peers who are not.
Great.
We'll touch more on that later.
Yeah. Thanks everyone for your perspective. Next slide, Christine. So now we're going to get into the current state of hospital and health system performance. We have a few introductory slides that we're going to get into here. So the first slide that we want to talk about is just the margin erosion that we've seen really starting back in the beginning of this year. 2021 with the COVID relief money, margins were somewhat elevated, but clearly this year has been a challenge for many of our providers across the country as expenses outweigh the net revenues that are being generated. So we anticipate that many providers, which is probably very familiar to most of you on the phone, will end up in the red at the end of this calendar year.
So let me, if I may, Lance, say a few words about sort of digging into what is driving some of those poor margins. And clearly, within the top 2 or 3 reasons for most health systems across the country is what's going on with labor expense. And our data demonstrates that organizations across the country are going to see a $57 billion increase by the end of this calendar year over what we experienced in 2021. Within that 57 billion, that all includes all skilled, professional, and unskilled labor as well. So when we think about, we'll in a few minutes here sort of dig into recruitment and retention strategies, but it's not just in nursing that we're seeing some of these significant shortages. So that is a pretty significant number. We're also predicting that will be almost $30 billion into contract labor, an increase over what we saw last year. Now, in some markets across the country, we're seeing those numbers soften a little bit to our benefit. However, there are definitely pockets of the country that are continuing to see contract labor expenses at a fairly high level. I think the really significant data point here to focus on is that contract labor expenses are nearly 500 times higher than what our organizations were experiencing pre-pandemic. And as what was observed in one of our previous slides here, this expense just can't continue. As we've all stated, this is unsustainable. So organizations are needing to give very serious thought to constraining capacity, and we need to understand the impact that that's going to have on not just our physician practices, but also patients coming into the emergency department as well.
Thanks, Therese. And the second largest expense on the P&L obviously is the non-labor expense, which includes supplies and purchase services. And just like with the workforce, inflation has definitely had a huge impact, with expenses for supplies projecting to grow by 11 billion in 2022, purchase services expected to grow by 7 billion in 2022, drug expenses continue to grow at a fast pace, over $1 billion in 2022. And then also with just maintenance, utilities, rent, lease, software, we're also seeing a lot of increases on the non-labor expense side. But overall, all expense categories we expect to grow 20 to 25% above pre-pandemic levels. So to really mitigate some of these inflation impacts, providers need to have a strategy around, how are they engaging their physicians? How are they partnering with their physicians? What's the strategy around value analysis? How are they leveraging key partners such as vendors, distributors, GPOs, to really come up with a strategic plan to mitigate the inflationary pressures that we're seeing on the supply side as well. Mark?
Yeah, absolutely. Thank you, Lance. One thing I think we've all experienced is, and the headlines, state it, but we're seeing lots of issues with trying to get the payers to be responsive, to give us good feedback, process claims quickly, respond to our denial appeals, et cetera. And as the survey showed and the news article showed, we are seeing that across the board. As I mentioned earlier, we continue to see more and more denials on what I'll call kind of fuzzy denials. Really, it's hard to define what's medically necessary based on some of the payers changing the rules or not really publishing the criteria they use. Also around the authorizations, as I mentioned earlier, having everyone within the organization know what's required is a challenge. That's kind of a moving target as well. Another thing that we've heard quite a bit about, which we've had several payers tell our clients that they are short staff and that's why they're not processing claims, or you're not getting your payment, or they're not responding to your appeal. A lot of question whether that's a disingenuous statement or not, and I'd have to say I think most hospitals we've been at, the revenue cycle teams have maybe not quite fully back to pre-pandemic staffing levels, but very close. I would expect we have the kind of same type of staffing capabilities on the payer side, so I question some of that. But we also see a lot of, it seems like more denials in the last year around delays related to getting our physicians credentialed or enrolled within the insurance companies. And of course, those do result in denials and delays of payments as well. So it's really pointing to a need for us to really become more proactive and maybe not the best word to use, but more aggressive in how we're monitoring denials and trending the actions of the payers at a payer level, as well as trying to figure out what the root cause is and how we can solve some of those situations proactively.
And then, Lance, we're also seeing issues with around patient discharge and length of stay opportunities. So some of the struggles, as you described above, are around negative margins and poor performance around pressures that are driving the increased cost. But what we're also seeing is organizations running into issues of patients are having to stay in the hospital longer because there is no staffing for the nursing home. There is no staffing for home health care agencies, so patients can't be discharged unless they can go to those facilities. We're seeing that ease a little bit in some of our clients, but that increase in length of stay is caused by that. But it's also, the other question is that we're also having staffing issues within the case management departments at hospitals and the staffing at the facilities. So is it we're having issues getting patients out, even from the hospital, even if the nursing home was accepting them. But then also holding patients in the ED, and that is a struggle that we're seeing. And really, it just start off on the wrong foot. Those patients who spend the first day or two in the emergency room waiting for a bed upstairs, it's just not the way we want to start a really robust admission to the hospital and a really top-notch care. So we're seeing that more and more, and those staffing shortages are causing that. But that ED pressure of getting those patients out of the ED is a definite concern. And we're actually seeing clients that are saying that their length of stay is longer. So the first 2 days, it may count against your length of stay, but it's really not counting when it comes to your overall getting the patients through your system. So they get upstairs and really the real admission starts, which is concerning.
So we've been touching a bit on the more hospital-centric way of thinking through this at a system level, but I think it's important to acknowledge that the physician enterprise component of our health systems is also having a very difficult year. As a general statement, our productivity volume has returned to pre-COVID levels, and in some cases even above, but our expenses are greatly outpacing our revenues. So as a result, the investments that we're having to make to sustain our physician enterprises are growing, and they're growing and outpacing, in many cases, inflation. The subsidies continue to grow every quarter, and you can see this in our physician flash report. As I said, volumes are up. And then I think the last thing that we're seeing is we're starting to see systems make very challenging decisions around service lines. And while the physician enterprise is a part of this, it's really a whole health system decision, which is to say, where is our margin coming from? Where is it likely to come from? How do we sustain our mission? How do we strike the right balance? And let's make sure that we're putting our foot on the gas where we can and where we can make sure it'll allow us to pay the bills. And where do we potentially need to back off a little bit, or things that we've been trying to grow that we're just not getting traction in the market and we might need to shift or consolidate. It's a very challenging time in the physician enterprise as well.
That's great. Thank you, Matthew. And the physicians are so important, to everything that happens inside a health system, that sometimes we forget about the physicians because we're so focused on the hospital side of things. So thank you, everyone, for contributing to that and sort of painting a picture of some of the challenges that we're experiencing in 2022. Now we're going to kind of jump over into some of the areas of focus and opportunity for performance improvement. This next slide came from our performance improvement survey. It was interesting because as you would expect, labor costs, where people are seeing the greatest opportunity for cost reduction, labor cost is the highest, about 46%, which is a little different than years past. Actually, labor costs were more like 3 and 4 on the list as far as opportunities go. So, Therese, maybe I'll turn to you on this one, since you're our resident labor specialist, just to give some insights on why this is. Maybe some of it's obvious to a lot of the participants, but maybe you can give us some thoughts on that.
As we travel around the country meeting with clients, this is sort of consistently number one on their list. And we're also beginning to see, and we believe that there is an opportunity to really begin to look at our data differently in order to really dissect what's going on with labor costs. So it needs to be looked at in more specificity than just what are we spending in contract labor and how much have we needed to increase sort of base salaries, and really begin to address these issues with understanding why is there churn, why is there labor churn within our organization. So we're going to get in a minute here into some of the leading practice interventions that we're seeing out there as it relates to labor cost. If I can also add, sort of piggybacking on my colleague Brian's observations in terms of what's going on the demand side, we're now beginning to see these two pieces, the supply and demand, linked in ways that have not necessarily needed to happen before. So much more understanding, sort of pulling in, to Matthew's point, what's going on the physician practice side. What does that pipeline of patients look like? Quantifying that in a way that allows us to fine tune what's going to be happening with labor.
That's great. Thank you, Teresa. And this notion around care delivery is a hot topic as well. It's scored much lower on the survey, but clients I know that we work with across the country, are trying to find new and new ways of changing the way care is delivered at the bedside. I don't know if you or Brian have any quick thoughts on that.
Or even a hospital at home, Lance. We're seeing many clients that are going out there and looking at new ways to send their patients. They're full, the inn is full. So what do we do? Where do we send our patients, and how do we put those patients in those hospitals at home? Is there a better way to do that? And that is just extremely innovative ideas going on around that country with that.
That's great. And trying to take some of the pressure off the bedside RN, right? Okay, great. Thank you.
So what we did here is we actually pulled some of the data from different clients and different looks. And one of the really important pieces here, and really what I want us to describe most, is how are you benchmarking your length of stay? What are your inclusions? What are your exclusions? How are you looking at the patients that are coming into your facility? So as you can see here, just for example, the different benchmarks, academic medical centers greater than 500 beds, peer group 1, looking at different benchmarks, or CMS's Medicare geometric mean length of stay. How are we looking at the patients? So as you can see here, those numbers change dramatically when it's based on the peer group. But the question is really how many of those patients have opportunity. So of your discharges, for example, this patient or this client here had 37%. If they're comparing to their peer group 1, which was 97%, 97 facilities in their peer group, 37% of their patients had discharges with length of stay opportunity. If we go over to Medicare's geometric mean length of stay, 59% of their patients had opportunity at their discharge with length of stay. So really what it's looking at is inpatient length of stay, what's your benchmark, and who are you comparing against? One area that we also really see clients sometimes forgetting about is those observation patients. So for example, this client here has over 1,000 patients a month discharged in observation. So what is their average length of stay? So here's, for example, this one had an average length of stay of around 42 hours. Those patients are taking up very precious beds. Why are they staying 24 hours? Could it be 22 hours? Could it be 24 hours? Could it be 30 hours? What does that mean to bed capacity and availability? And how are we looking at them? We're seeing best practice there is looking at those patients every 4 hours. First of all, we're going to verify they should be in observation. The second thing is we're looking at them every 4 hours. Are they inpatient or are they observation, or do they need to be discharged? So the question continues being reviewed to make sure that we're keeping those beds emptied and patients moving through expeditiously.
And Brian, on the inpatient side and the observation side, I think back to your pillars that you put out, in your methodology when you work with our clients. What are some of the key pillars or changes that clients would need to consider or make to improve both of these, inpatient length of stay and observation?
I first of all, multidisciplinary rounds. What do they look like? Are they occurring every day? Are they occurring Monday through Friday only? Do we have a modified process on weekends? We also would look at those areas such as getting the patient's status right at the front door. If they're coming through the emergency room or they're having outpatient and inpatient surgery, are we getting the status right every single time the best we can? Understanding that things may change, patient condition may change, those types of things. Really, are we getting it right? And then the other one that I feel like we need to continually talk about is around physicians talking to physicians. There are times when I'm a nurse, I will have a discussion with the physician about a case, but I just sometimes need the doctor to talk to another doctor about the case and have an understanding of why this patient needs to stay 3 more days to be worked up for an issue. Right now, we have an example, we're going to stay 3 more days, but we have 40 patients waiting in the emergency room for an empty bed. Can we do that on an outpatient basis? And it's having those hard discussions, and we're seeing more and more of that occur.
That's great. And I know the work that you do really impacts the work that Mark does on the revenue cycle side as well and helping drive down denials. So that was great. Thank you.
So there's a few comments that I'd like to make in terms of strategic interventions around workforce that we feel are requirements. So there has been, over the course of COVID, a lot of frenetic activity around attempting to get our department staffed, to try to stem the tide of resignations. And we are now seeing and certainly suggesting that organizations sort of take a step back and have a more strategic perspective around what's required in order to build a sustainable, strong workforce going forward. So I think it's important that we understand, not just in healthcare, but sort of across all industries, what are the significant drivers of turnover? And they are lack of career development and advancement. And I encourage us to sort of think about these because over the course of the last many years, many of us have seen our organizational development and educational internal departments sort of erode over time. And we're beginning to see a need in order to bolster those departments to fix the number one reason for turnover, and that is lack of career development. The second largest driver is inadequate total compensation. So obviously not just base salary, but in terms of other benefits and the need to look at those with flexibility. The third is uncaring and uninspiring leaders. The fourth is lack of meaningful work, and the fifth is unsustainable work expectations. So we are now beginning to experience sort of the sequelae of figuring out how do we get folks to come in and produce more hours with us. However, we're now beginning to see that sort of turn into a significant driver. We would suggest, and it's our point of view, that every organization, whether you're a large multi-hospital enterprise or a small community or rural organization, you need to have some activity or an eye on every one of these verticals. So things like what's going on legislatively. There are now 17 states that have enacted legislation around controlling contract labor costs. So those are everything from capping rates in some states to getting rid of liquidation penalties in order to convert those contract folks onto our payroll. So whether you're a system that has the capability of having a legislative presence in Washington, you still need to sort of keep an eye on what's going on in terms of legislation. In terms of enhancing the pipeline, we sort of think about that in the context of outside in and inside up. So every employee that's being employed by the organization, on their first day of employment, we need to begin to have conversations with them about their next opportunity within our organization. This is recognizing the fact that healthcare is not unlike other industries. We need to plan for the fact that our employees are going to be with us for 3 years. So at the end of 3 years, if we have not created a pipeline to other opportunities, we're going to lose them to competitors. Certainly in terms of recruitment, we need significant strategies there, being driven by sort of a new look at our data to understand what is our cost to recruit employees. Certainly retention, a really good example here, a leading practice. If you are waiting for exit interviews to determine why employees are leaving your organization, that's way too late. They are disengaged at that point in time and are of the mindset that they do not want to burn a bridge. So the alternative, sort of leading practice here, is what many organizations are calling stay rounding. So as leaders getting out and asking the questions of employees, what do we need to do to keep you employed here, and what are those elements of your work that you find satisfying? As Lance alluded to earlier, lots of leading practices regarding model of care. Certainly sort of a big driver there, and we've said this for many years, we need to get serious about it now, is folks working to top of license. We just simply do not have the professional workforce anymore for our employees to not be working at top of license. And then certainly looking at technology and digital enablement. Our survey showed that about 18% of our organizations have some level of activity there. We're seeing that sort of across the spectrum with those enterprises who have an investment arm, who are perhaps a little bit more entrepreneurial, lots of activity happening here. However, irrespective of the size of your organization, folks need to be looking at that as well. Next slide. So we would also suggest in terms of data-driven interventions, really beginning to focus on much more precision around demand-based staffing and scheduling. The days of looking at an average daily census marked at midnight to drive budgets just does not give us that specificity that we need in order to have the right staff throughout the course of the day. And really beginning to understand what that churn in the middle of the day looks like. If we are not adequately staffing, there are going to be issues with getting patients moved through the system and discharge planning happening in a timely fashion. We now have the computational capability in order to do much more sophisticated modeling, using optimization science to help us drive some of these issues. Next slide. So let me sort of end here in terms, it all sort of always circles back around to data requirements, and we would suggest that leading practice it really requires that we look at the sort of next level data in order for us to intervene appropriately. So perhaps for the first time, actually, and many organizations are beginning to do this, to do a housing market analysis. Is it affordable for our workforce to live in our communities? As we know, housing prices in many markets have exceeded what's gone on with salaries. So understanding what that looks like, and perhaps looking at some interventions that tie into a total comp package as it relates to that area. I won't go into each of these specifically, but there is one that I'd like to call out that sort of relates to the interventions that I talked about earlier. And that is, if we are truly going to deploy a strategy outside in and inside up, we're seeing leading organizations now step away from very specific job descriptions to what is being called job architecture. So looking at sort of broad job descriptions and within those descriptions, being able to identify sort of what is the next step in terms of the trajectory of an employee within our organization, developing career paths, and being able to demonstrate to the millennials and Zs what does salary mobility look like for them within the organization. So some interesting strategies there. Back to you, Lance.
Yeah, thanks, Therese. Mark, I think you're up to talk a little bit about revenue cycle. You're on mute, Mark.
I knew I was going to do that.
You're good now. We can hear you.
All right. So around the revenue cycle, really, we've been focusing recently in really three key areas. And as I mentioned earlier, around denials management, really got to keep focusing more and more on that issue and those challenges there. What we've been seeing is the need to really strengthen the integration and the cooperation between the care management, case management utilization review, and the physicians with the revenue cycle to make sure that the results, the financial impact, the financial results, the rework that's happening in the back end is getting back to the front end so that we can help coordinate efforts to prevent those. And that really is driven by a really strong denial management committee that includes both clinical and revenue cycle stakeholders. Another thing that we've been seeing clients do to really help in the denial area is moving towards monitoring and responding to initial denials rather than letting that kind of drive our root cause analysis and our prevention efforts rather than denial write-offs. Denial write-offs are the actual financial impact. However, most of our clients, those are on average 12 to 18 months old because of the delays we take in appealing and fighting, and eventually, the time passes. And so you're kind of chasing a ghost if you're looking after trying to improve processes by looking at accounts that are for more than a year ago. So really shifting more and more towards the initial denials to drive that. And again, we focus on authorizations, which is really making sure that we clarify who's responsible for obtaining the authorization. One thing we do see is a lot of times we're getting the physician authorization by the referring physician, but the hospital authorization is either not obtained or not recorded appropriately, and we get denials from that. Another issue is around trying to make sure that we've got some type of a verification or reconciliation process for some of these very high cost authorizations or authorization for high cost services. We want to double check those a day or two before the procedure or the service to make sure that the authorization is correct, that what was on the authorization, the service that was authorized, is actually what is scheduled to be performed, and that you know, the date that was approved for is still valid. And then around medical necessity, again, going back to the front end to make sure that we're coordinating our efforts with care management and the providers. Also, we'd like to integrate CDI into that process. Hopefully CDI is able to help kind of reverse engineer some of these denials reasoning that the payers are coming up with, and allow us to figure out what works, what doesn't work, and making sure that we're educating the providers and and the physicians on how we document and make sure that we are selecting a patient status or treatment plan that's going to match what the payer is expecting, and is clear that is going to address their concerns about whether it was medically necessary or not. Another thing we do is we also ask providers to really dig into timely filing write-offs. I'd say often that's probably like the third highest write-off category we see. If we start digging into the history of those in a detailed level, we'll find that they really are not timely filing. It's not because someone in the business office never submitted a claim. It's primarily authorization and medical necessity denials that have been in an appeals process for an extended period of time, and eventually we just ran out of time before we had a clean claim submitted and triggered a timely filing write-off. So a good idea to dig into that, because that will change a lot of your denial categories and move some that may have been not looking, you know, not popping up on the radar, suddenly be bumped up on the list as a priority. So make sure we take a look at that. Around CDI, we continue to see more and more focus on CDI, trying to make sure that we're documenting the care and the complexities of the patient condition or history. Want to make sure that we're doing that appropriately, to make sure we're getting proper documentation, making sure that the severity and illnesses of our patient population are reflected. Also, want to make sure that, as I said, we want to make sure we're using them to identify and spot changes in payer requirements and their behavior, so that we can adjust accordingly proactively before the claims are going out the door. And we also make sure that they're included in the denial management committee structure. The input and their ability to kind of cross the line between revenue cycle and the providers is very key to making sure that we're getting good information, good communication with the providers, and facilitating the feedback from the providers back to the revenue cycle. And then last but not least is around, we'll call it financial counseling, but it's really everything around patient responsibilities. Point of service continues to be a challenge in many areas. Point of service collections. You know, we're doing better now as an industry about getting patient estimates together and providing those, but we need to keep focusing on making sure they're accurate and that all patients have an ability to look at that and that we're communicating their responsibility proactively. Additionally, we want to make sure we've got really good, strong point of service collection processes and policies in place. Is it happening across the board? If there are departments that are doing check-ins and registrations on their own, do they have requirements to do point of service collections? And then around making sure that we've got the financial counseling support to help find patients other coverage or other payment options. We need to be able to give patients options and multiple choices on how they can pay for their liabilities. Most of our patients don't have that kind of cash sitting around to pay out of pocket. So we need to make sure that we can fit a program and a process to fit their capabilities. And then also need to make sure that we're looking at our charity care policy. Often we'll find that some hospitals will have a high bad debt write-off level, but a low charity level. There's a case to be made that, you know, is our bad debt policy stronger than our charity policy, appropriately balanced? We want to make sure that the charity care is really, the charity care program and policy is really driven to find and serve those patients who need care but cannot afford it, not necessarily those that need it and can but won't pay for it. So in a nutshell, that's, like I said, kind of the three big areas that we've been focusing lately, and I think it will continue to see more and more pressure in those three verticals.
Thank you, Mark. And it's so important to have a strong revenue cycle in addition to a strong cost management structure and process as well. And your revenue cycle looks at both the provider side, physicians, as well as the hospital side, right? So it's pro fee and hospital based. Yeah.
Actually, they're so integrated now, you really can't separate them. They're two distinct functions and two distinct priorities, but they are just so tightly integrated that you really can't separate them 100%. So you really got to tie them together and figure out where it makes sense to cross-pollinate, and then where you need to have specialized focus on, the professional side versus the hospital side.
That's great. That's a nice segue to Matthew Bates. He's going to be talking a little bit about provider performance and opportunities in that area. Matthew.
Well, great. Well, this has increasingly become the framework or the lens that we're finding is helpful to think about performance improvement as it relates to physicians. And the key is not any one of these things. It's actually how do you get these in balance with each other? So I'll start with the bottom, and that is volume. Do you have adequate volume in your market and or market share to go out and get the volume you need to support the enterprise? Or are you aspirational? I was with a group the other day, and they said, well, if we capture 100% of the market share, we could get all of our doctors busy. And I said, have you ever captured 100% of the market share in anything? And they were like, well, no. So we had to have a reality conversation on what's a realistic volume for you today and in the near term. The next increasingly is access. And I would say this is becoming an area that Mark and I collaborate regularly in as it relates to thinking about patient access, not only as a revenue cycle activity, but increasingly it's coming down to more of the operations of the practice. How frequently is that physician in clinic? How many slots are available? Are patients able to self-schedule? Are we effectively leveraging advanced practice providers to get people in the door quickly or get initial referral contacts made and make sure that we keep folks in the network? And then backlogs. I'm with a system right now that has colonoscopies that have been referred by primary care for colonoscopies that are over a year old. So working that referral backlog down is not only a great way to make sure we're serving patients, but it'll have a marked improvement on the financial performance of the organization. And then finally, productivity. Are our doctors busy? Are they working effectively, again, as teams with advanced practice providers? Do we compensate them appropriately for the amount of productivity they do? We want to make sure as doctors are working harder and volumes go up, which means many of them are working harder, we're paying them appropriately and in line with that. And then increasingly, I think it's very important to understand downstream revenue. I have a health system that just came to me and said for the first time ever, they looked at their orthopedic service line and realized they're losing money in orthopedics. And so we're having to have a really challenging conversation around if you're losing money in orthopedics, what's going wrong and what do we need to do differently? So that's kind of thinking about those and getting those balanced. And of course, in the center there, you see leadership because physician leaders are critical to all this, right? This is something that requires engagement of the physician leaders. The next slide here I wanted to touch on is this topic you've heard me mention a couple times, which is the rise of the advanced practice provider. And when I first saw the data on this slide, I thought it was wrong. I challenged the team. I said, this can't be right. You guys go back and relook at the data. And they did. And they came back and said, no, it's right. And we've double checked, triple checked it. And what this data shows is that more nurse practitioners are entering the workforce every year than physicians are coming out of residency. Let me just say that again. More advanced practice providers enter the workforce every year than doctors. So if you are not effectively leveraging nurse practitioners and physician assistants in particular, you're getting behind the ball. And what we find is about 40% of the entire, if you will, traditional physician enterprise is now actually advanced practice providers. So I think a really important space and one that higher performing organizations are definitely leaning in on. They're using effectively the nurse practitioners and the physician assistants to allow their physicians to focus on things that only they can do, but also provide access to patients. And then one more we wanted to touch on here. Next slide. I think I'm sorry. I think what we want to do here was move it to this group and questions from our audience. Lance, I'm not sure what the process here is. I'll hand it back to you.
Yeah, no, that's great. Thank you, Matthew. I know we're running short on time. I think we're actually at our time, but we do have a few questions for those of you that can stand on. We'll go through a couple of these. I think the first question probably is to you, Therese. The question is, where regionally is the nursing shortage and contract labor use the greatest? So are there regions of the country where there's shortages more acute and the use of contract labor greater than in other regions?
Two that come to mind immediately based on our client experience in the Northeast, Maine, New Hampshire, New York, and then California continues to be, that had been an area with the highest contract labor going into the pandemic, and it remains so. So those two pop to mind immediately.
Okay, great. And then Brian, we'll move over to you. There's a question posed. How are clients dealing with post-acute placement, which is driving length of stay up? So moving patients out of the hospital into another level of continuum of care.
Yeah, I'm having preferred provider agreements with specific post-acute entities. Also, what is the process of who's actually doing the authorization? Are we sending the information to the nursing home, to the rehab facility, to the home care agency? Or are we doing it on our own? We're finding that if we're doing it on our own, we're verifying it where it may sit around a day or two at the nursing home or the home health care agency. We're getting it done that day. And we don't need nurses to do that work. We can have case management assistants or assistants help us get that done. So those are a couple ideas.
Great. And then the last question, back to you, Therese. This participant is wanting to know any states that are putting caps on contract labor. Any legislation that you're aware of? Any states in the country that are pushing through legislation to cap contract labor costs?
Yes, Michigan just enacted legislation to cap costs. Illinois, for example, has legislatively eliminated liquidation fees. They also, for transparency, agencies need to post on their websites what the rate to the hospital is and how much the nurse is or other care provider is getting out of that hourly rate. So there, as of my last look at this, 17 states have some sort of version of this happening. Quite frankly, Michigan seems to be the most assertive in terms of capping rates.
Okay, great. And then we've had several questions about the presentation, and can we send that out to the participants? And Jim will be sending that out to everyone that joined us today. Just want to thank everyone, the presenters today, as well as the participants. I really appreciate you taking time out with us today, and I hope you have a great rest of your day and a very happy holiday season. Take care.